Welcome to my podcast. Today I'm going to talk about one of the cases that you might face in the clinical setting, and any doctor should be alert about those kind of symptoms. So after you introduce yourself and double check the patient name, date of birth, the patient will be like a young university student who might present with headache, mostly in the front part, so it's frontal headache. And he says that the worst thing it's happened basically in the morning and is associated with nausea, vomiting, and anorexia. However, there isn't any other symptom. He denies symptom of weight loss and has no past history or family history of similar thing. And he's normal weight, normal lifestyle. And he would say that medically he's just using topical benzyl peroxide for his acne. And you will just start to think what might be the reason for this frontal headache. And you will just try to ask some questions and probably arrange for central blood tests, like for instance full blood count, urine electrolyte, inflammatory marker, thyroid function test. Probably you will check his cortisol in the morning and certain other investigation, like for instance calcium, phosphorus, vitamin D, and maybe arrange for MRI brain because of the symptoms. So from this concept, you will just ask the patient, do you have any thoughts? What might be the reason? Do you have any explanation, for instance? Maybe the patient has some thoughts of something that could be linked or related to his symptom. And of course, the patient, when he says that I'm having frontal headache, you need to do neurological examination and you need to do fundoscopy. So once you do the fundoscopy, you find that his optic disc is kind of swelled and the blood vessel kind of obstructed, and with a flame-like hemorrhage, which is suggestive of papilloedema. So in this condition, always we will have some differential in our mind. Say, for instance, anything that could be increasing the intracranial pressure, like space-occupying lesion, like cerebral venous sinus thrombosis, history of meningitis as well. If the patient says, I'm having probably fever, intolerance to light, and of course the skin rash will be late manifestation. You will ask if the patient has any medical history of any notes, for instance hypertension, could be hypertensive retinopathy, or endocrine problems like hypothyroidism or hypoparathyroidism or Cushing syndrome, or if the patient is taking certain medication, it could be raising the intracranial pressure. As we all know that he's already in topical benzyl peroxide, he's not taking any tetracycline or minocycline, which is well known for increasing the intracranial pressure, or vitamin A. If any of that cannot be found, of course, you will assign it as idiopathic intracranial hypertension. So when you see, for instance, the papilloedema, you need to define and describe what's been seen exactly and how the symptoms started. So apart from the examination and the blood test, all of that came back normal. So in this condition, the typical manifestation would be assigned with idiopathic intracranial, raised intracranial pressure, which manifests with headache and nausea, vomiting, pulsatile tinnitus, diplopia in certain situation, or transient visual loss. And in certain situation, when you do the neurological examination, including the cranial nerve, there might be certain finding like abducent nerve, which could be involved, and you just need to carry on about the examination that you feel it's needed in this kind of presentation. and you take it from there. Also, you might arrange, apart from the blood investigation, lumbar puncture, which could help in the diagnosis and rule out certain differential. Say if, for instance, there is elevated opening pressure, which you can see when you do the puncture, collecting the cerebrospinal fluid. And you will arrange then, you will talk to the patient what might be the thought that you have about this condition, and you will see how you can take things forward and manage it. And we know that optic nerve should be protected if there is any raised blood pressure, pressure. You need to take action immediately because optic nerve is mostly for vision, so we need to preserve the vision. And being stated also, if there is any issue with increased body weight, you need to arrange for a strategic plan as well. And of course, in this situation, the only thing that we can have to reduce the intercurrent pressure and help protect the optic nerve is carbonic anhydrase inhibitor like acetazolamide, which is we all know long time ago. And there is other called topiramate, which is weaker. It's a weaker kind of carbonic anhydrase inhibitor, which offer additional benefit as well to improve the pain management. And it has also teratogenic effects, so we need to explain if the case was of a woman in order to arrange for the appropriate contraception. And if all of those measures did not work and there is a surgical need, in that condition you will do fenestration, which is basically like tunneling through the optic nerve sheath. Or of course there is another operation called ventriculoperitoneal or lumboperitoneal shunt, which indicated in certain resistant cases. So by that, I hope that I covered one of the cases which you might see in the clinical setting, which could be anything that leads to increased intraocular pressure and the manifestation that it can be presented, which can be confusing sometimes with other things that can lead to increased intraocular pressure and overlap between the symptoms. Let me know how you find this podcast, and if there's anything you would like to add from your experience, you can comment and I can come back to you. Thank you.